we go. Dr. TJ sees patients down in our shore offices. And I'll give you a brief bio and then he will get started with his talk. He is a board certified orthopedic surgeon with a subspecialty in sports medicine. He is a professor of orthopedic surgery at the Sidney Kimmel College of Medicine at Thomas Jefferson University. He is an associate director of the Sports Medicine Fellowship Program, as well as the associate director of sports medicine research, and serves as instructor at numerous arthroscopy courses. He specializes in sports medicine and shoulder surgery with expertise in shoulder, knee, and hip arthroscopy and reconstructive procedures. And I will turn it over to you. Thank you so much.
Thank you. Thanks for letting me spend the evening with everyone on the webinar. It's my privilege to talk to everybody tonight about shouldering pain, and about shoulder pain in general. So it's always helpful to, I think, educate patients so that when they have little problems, they can come to us and sort of have a little bit of background on what they think might be going on. We actually love when patients do a little bit of reading on their own and come in and sort of help us along the process. So let me see if I can. Can you guys see my screen okay? It's just not
Yeah, I can
advanced.
see it fine. It looks
Of
great.
course, no, it's not advancing. How about, okay. Yeah, it's weird. There we go. All right. A little bit of background on me. I know Kristen already introduced me a little bit. So I'm a sports medicine surgeon, also with a lot of training in shoulder surgery as well. I did my medical school at Rutgers, my residency in Philadelphia at the University of Pennsylvania, then a fellowship in sports medicine and shoulder surgery at the University of Pittsburgh. I've been practicing locally in the Delaware Valley for about 20 years, and I see patients out of our Egg Harbor and Manahawkin locations in South Jersey at the shore. And I'm originally a South Jersey native, so I grew up loving the Phillies, the Flyers, the Eagles, um, and all the Philadelphia sports teams, 76ers. And I do that with my family. So I have three kids. I've got a great wife, and we love South Jersey. We love the community that we serve. So hopefully I'm talking to a lot of people here throughout the Delaware Valley tonight and beyond. So first, a little plug for my partners in our practice. Why do I think patients should choose Rothman? Well, one of the things that I think we do really well is that we really treat patients in the communities in which they live. So we meet patients where they are, and we bring a lot of expertise. Like we have, especially in sports medicine, for instance, I think we have one of the best and most robust sports medicine divisions in the entire country. We have more than 16 fellowship trained orthopedic sports medicine surgeons alone. We're all highly fellowship trained. We all do research. We all educate residents and we educate patients. And I think, my family receives their care at Rothman. And so I trust no one else with their orthopedic care. And I hopefully people in the community do as well. So that's my plug. We've got a lot of offices throughout. So hopefully if there's ever an orthopedic need that you reach out to one of our local practices and get plugged in. So anyway, let's get started. So I think whenever we talk about the shoulder, it's good and helpful to start with the anatomy. I mean, what we really are as surgeons are anatomists. I mean, when patients come in and complain of pain in certain locations, it's really helpful to know what structures are underlying where they hurt. And so the shoulder is one of the most interesting joints in the body because it has the most range of motion of any joint in the body. It has to put your hand in space. And so when you have to put your hand in space, you need a joint that's able to sort of rotate almost fully around the body in order to achieve that. And that is, in fact, the shoulder. So the upper part of the humerus bone is called the humeral head. That's the ball of the shoulder. It's retroverted, which means it's kind of tilted backward by about 20 degrees. And that allows us to move our arm out to the side without dislocating it. The glenoid socket, that's the socket of the shoulder, which is part of the scapula, is also slightly retroverted or tilted backward a little bit, again, to mate where the humerus is in the ball, and also to allow for an increased range of motion. Then we have the collarbone and the scapula, which articulate with the ball as well. And so that whole process, that whole anatomical area, we call the shoulder suspensory complex. It's the entire area of the shoulder. And we see problems that can originate from any of those things. And so kind of having that overarching anatomical framework really helps us to figure out where problems are coming from. So that's the bone. And then we have the soft and hard tissue around the shoulder. The hard tissue includes the cartilage, the lining on the end of the ball and socket joint. When you lose cartilage, we call that arthritis. So cartilage is the smooth, frictionless surface of the joint. Around the shoulder, we have rotator cuff muscles. These are four muscles that help to keep the ball of the shoulder centered in the socket. Around that shoulder socket, we have something called a labrum, which is a cartilage ring, almost like a washer that deepens the socket and helps to seal the joint. You can tear the labrum, which is really a crack in the seal of the shoulder, and that can cause problems like instability or pain. And then lastly, we have the capsule or the ligaments. In the shoulder, we call them the capsule, and that's the structure that surrounds the ball and socket joint deep to the rotator cuff that holds the joint in place. The ligaments stabilize the joint. The rotator cuff and muscles around the joint help to move the joint. So we have these stabilizers of the shoulder, and we have something we call primary or static stabilizers, which means they're always there to provide stability. And then we have these things called dynamic stabilizers. That's the muscles around the shoulder that contract as we move the arm in order to provide increased and added stability to the shoulder. Those dynamic stabilizers are the rotator cuff, in addition to the nerves that innervate the shoulder that help those muscles fire and work. So you can have a problem with the rotator cuff, you can have a problem with nerves that go to the shoulder, and both of those can cause you to feel unstable or weak. The primary stabilizers are the ligaments, the concavity compression of the joint, which just means the fact that the joint is mated well and there's fluid in it that basically holds it together. And then you have the bone stability and the ligament and the labrum complex. All that helps to stabilize the joint. So whenever somebody comes to us and says, my shoulder feels unstable, it's up to us to figure out, is it an anatomic problem where they may have torn something, or is it more of a dynamic problem? They've got some weakness in the muscles surrounding the shoulder. The muscles are a huge part of the shoulder. Because the shoulder has so much range of motion, it's prone to have instability or dislocate, and having strong muscles around the shoulder is really important to help to prevent that. The big muscle on the outside of the shoulder is called the deltoid muscle. The lat muscle is this muscle underneath around your shoulder blade that helps to stabilize the shoulder joint. Your trap muscle is the muscle on top of your shoulder that goes towards your neck. The serratus is a shoulder blade muscle that helps to stabilize the shoulder blade. And then you have these four rotator cuff muscles, all with Latin names that just surround the joint. And the names kind of tell you where they are. So the subscapularis is in the front, supraspinatus on the top, and the infraspinatus down below and towards the back, along with the teres minor. And those four muscles are collectively referred to as the rotator cuff, because when you look at them from the side, it looks like a shirt cuff coming across and looking over on the bone. So we have this expression in medicine that when you hear hoofbeats, think horses. And so what I'm going to do tonight is talk about the most common things that we see as shoulder specialists when patients come to the office. In other words, sure, we might have patients that come with this very bizarre thing once in a while, like a cyst in the shoulder that compresses the nerve. But most of what we see, what we call that bread and butter, is going to be the most typical thing that happens in that patient age population. So I think as we talk about shoulder problems, it's really helpful to think about them on an age-based approach. And that's what I've kind of done here. You know, we have this age-based approach where we see patient populations of certain ages, and they tend to present with certain shoulder problems. And that doesn't mean you can't see people a little older or younger with different problems, but this is sort of like I said, you know, when you hear the hoofbeats, think horses, not zebras. When we have teenage or young adults between the ages of 14 to 30, the most common problems we see in them are instability. A young athlete goes to reach for a ball, somebody hits their arm, and they dislocate their shoulder. That dislocation, like that x-ray shows right here, needs to usually be placed back in on the athletic field of play or in the emergency department under sedation. But dislocations can affect the labrum. The labrum is the cartilage ring, the stabilizer inside the joint, and you can tear your labrum, and that can result in instability. So you might have an instability event, but if you tore your labrum, it can happen repetitively. Fractures can happen almost at any age. At this age, we'll see a lot of collarbone fractures or clavicle fractures. We'll see growth plate fractures as young children still have open growth plates. We might even see humerus fractures of the upper arm or upper arm bone fractures or scapular fractures if it's really violent trauma. Shoulder separations are where the collarbone separates away from the scapula or the shoulder blade. There's ligaments that hold that in place. If you land directly onto the collarbone, sometimes those ligaments can pop and your clavicle can sit up high relative to the shoulder blade, and we call that a shoulder separation. A lot more common in younger people than older people, just because they engage in higher risk activities. Once we get to that middle-aged person, we start to see more the rotator cuff come into play. Tendon issues. We'll see rotator cuff tears. They might be acute tears, which means somebody falls, on their shoulder, they rip the rotator cuff, and now they have difficulty lifting their arm. They can be chronic or degenerative tears in this age population. Somebody pitched when they were younger or did an overhead racket sport and kept playing and playing, and over time, that wear and tear of the rotator cuff results in a full tear. You can have biceps tendon problems at the shoulder, not the biceps below or where the elbow is, but here in the shoulder, there's a long head of the biceps tendon which goes into the shoulder, and that can tear. And again, once more, we have fractures, and we can also have shoulder separations in this age population. As we get to our later years, patients over the age of 55, once more, we see a lot of rotator cuff issues, and these tend to be more chronic or degenerative at this time. Although you can fall and tear your rotator cuff at this age, it's usually what we call an acute on chronic tear, meaning somebody has a tear in the rotator cuff pre-existing, they fall and they tear it further, resulting in more dysfunction of the arm. Once more, the biceps tendon can play a role here. And then we'll start to see a lot more arthritis. If you look at this x-ray here, I have two x-rays here. This one here on the left on the screen, that's a normal x-ray of a shoulder. You have the ball, you have the socket here, and you have normal space of the joint in between. Now, cartilage doesn't show up on x-ray, so you have that narrow, that space there is actually occupied by cartilage. It's not really an empty space. On the right, you have an x-ray of somebody who has arthritis. You can see the ball in the socket without a lot of space between them. And that loss of space means there's no more cartilage in the joint to lubricate the joint to provide that frictionless environment. So now patients are rubbing bone against bone and getting pain in the shoulder. So we'll see arthritis a lot more commonly as people age. But again, in certain patient populations, like people who lift weights, people who have inflammatory conditions, or people who've had previous trauma when they were younger. Once in a while, it happens, just normal wear and tear as well. Fractures can happen at this age as well. As we get older, we lose bone density. So a routine fall can sometimes result in a fracture in or around the shoulder. And lastly, I'll talk about a condition called cuff arthropathy. That's when you have a rotator cuff tear that's gone on so long that not only do you also have the stigma of the rotator cuff, but you have arthritis that is the result of that long-standing rotator cuff tear as well. And that's a specialized condition with specialized treatments. So, one of the things that patients often ask is, how do I know when something's bad? When do I need to go see the doctor? Any significant trauma, if you fell hard, if you were in a car accident and you have shoulder pain that is not really explained by just a mild ache in the muscle, you should probably seek treatment, get an x-ray, make sure that we're not missing something. If you have pain that lasts longer than 6 weeks, routine bump, sprain, contusion, usually that pain is going to go away after a couple of weeks, but pain that just kind of persists longer than that time, you should probably get checked out. If you have functional limitations that impair your activities of daily living, meaning you have difficulty caring for yourself, you have difficulty cooking, if you're a young athlete and you can't play your sport because the shoulder pain is really impairing that ability, then you should seek treatment. If you fell and now can no longer lift your arm, early treatment is best in that instance. If you have obvious deformity, collarbone used to be sitting down, now it's sitting up. You see a big lump in the arm, you think you might have fractured something. If you have pain that now is starting to happen at night, it's not just mild, but it's keeping you up all night long. You can't sleep anymore. The shoulder pain really hurts. Rotator cuff problems and arthritis of the shoulder a lot of times will bother patients at night. Is it recurring? Did you have pain for a while? It went away, but then it came back. Recurring pain is something that you probably should seek treatment for to make sure you're not missing some underlying diagnosis. And lastly, instability. Does your shoulder pop in or out of socket routinely? Did it happen just once? Has it happened multiple times? That's certainly something you want to get checked out, because the more times that happens, the more at risk your joint is of progressive degeneration. So we're going to start in the office with a routine evaluation. The things that are really important to us, number one, like we said, we have this age-based approach. When someone comes in the office, we know how old they are, we ask them their age, and we sort of say, all right, most likely it's one of these conditions, but we're keeping our minds open until we ask a series of questions. Chronicity, how long has the pain been there? Is it your dominant arm that's affected? Is your non-dominant arm? What's your activity level? Are you a high-level athlete? Are you a weekend warrior? Are you somebody who plays sports at all? Or do you have a physically demanding job? These are things we really need to know because it does affect treatment. If you're nearing the age of retirement, how many more years do you have? Is it a laborious job? And do you want to do another 5 or 6 years? Or did you have an injury and now you're thinking in the next 6 months you might retire? These are really important details to share. And of course, it's always confidential, but we want to know these things so we can most optimally treat you. Where is the pain? Is the pain localized to the front of the shoulder? Do you feel it more in the back? Do you feel it down the side of the arm? A lot of patients who have rotator cuff tear pain will feel pain down the arm where their policeman wears this patch on his uniform. We'll call it policeman's patch pain. How bad is the pain? We'll ask you to rate it on a scale of 1 to 10, 10 being pretty severe, 1 being mild, 5 being intermittent mild discomfort. What was the nature of the onset of the pain? Was it trauma? Did the pain come out of nowhere? Did it come from, did you paint your house one day and then the next day you started to develop pain? So we want to know the circumstances under which the pain began. Does the pain radiate? Does it go below the elbow? Does it just stay here? Is it associated with numbness and tingling where we might think you have a pinched nerve in your neck also? And have you had any prior treatment? Certainly, if you've already had physical therapy and injections, that starts to narrow down our treatment options and what we can offer you. Next is the evaluation, right? The examination. So we've gotten your history. We have a general idea of what might be wrong, but now we want to put your shoulder through a series of tests. The first thing we do is look. Do I see deformity? Is there asymmetry? Do you have big muscles on one side, less muscles on the other? We're going to palpate your shoulder. Does it hurt in the front? Does it hurt to the side or the back? We're going to do strength testing and range of motion testing. We might do provocative testing, as the video here shows, where we're moving the shoulder front and back to see how stable it is. We might compare you to your opposite shoulder, right? So we want to make sure that if you feel unstable on one side, is that just anatomically how you are, and the other shoulder is about the same? Lastly, we want to look at your neck, make sure you have full cervical neck motion, make sure you don't have a pinched nerve in your neck, and make sure that you don't have any numbness or weakness in your hand to indicate that there might be an underlying nerve issue. Then once we get the history and the examination, most of the time we have an idea of what your diagnosis is. The diagnostic studies and the tests that we order are oftentimes used to rule in the diagnosis or in order to sort of evaluate for treatment. We're always going to start when someone comes in and get x-rays. Sometimes patients will say, well, why do I need x-rays? Well, we really just want to make sure we don't see abnormal calcifications, that we don't see a tumor in your bone, that maybe this is just really severe arthritis. So x-rays are actually very informative in ruling out a lot more serious conditions. Hopefully the x-ray is normal. And so we might use x-ray, we might use ultrasound. Ultrasound's a quick and easy way sometimes to look at tendon issues. We might get a CAT scan if we're concerned about a certain type of fracture, because CAT scans are really good at looking at bone anatomy. An MRI might be ordered if we think you might have a labral tear or a rotator cuff tear, because MRIs are much better at looking at soft tissue. We might ask the radiologist to put contrast in the joint, called an MRI arthrogram. That increases the sensitivity when looking specifically for labral tears. And some patients can't get MRIs. They may have pacemakers, they may have pain stimulators in their lumbar spine, and those devices are not necessarily MRI compatible. In that instance, we'll get a CT arthrogram. That's like an MRI arthrogram where they inject dye in the shoulder, but we get a CT scan to help evaluate the soft tissues and the bone anatomy. So this is an example here of a CAT scan. On the left, you see a normal CAT scan of the shoulder. We see the ball on cross-section, we see the socket on cross-section, and the muscle soft tissue. You can see how good CAT scans are at looking at bone anatomy, but they don't do a great job of showing the tendons or the ligaments of the shoulder. On the CAT scan on the right, you can see an example of somebody who dislocated their shoulder out the back. The ball is not centered in the socket. In fact, the center of the ball is outside the joint relative to the center of the socket. So this is somebody who dislocated their shoulder. Their x-ray did not look that abnormal, but the CAT scan clearly shows the bone is not articulating in the socket. This is an example of an MRI arthrogram. So just move that. So here on the left, you have a normal MRI. You can see the ball of the shoulder here. The white is fluid in the joint that's been injected by the radiologist, and we get really good anatomic detail of the muscles around the shoulder, and this black structure here is the labrum. This is an example of an MRI arthrogram of somebody who has a labrum tear. This is the labrum at the top of the shoulder, and we can see fluid undercutting the labrum. It's in the substance of the labrum where it shouldn't be. On this MRI, we don't see that. And then lastly, this is an MRI to the right of a rotator cuff tear. This is someone who tore the rotator cuff. Here's the ball of the shoulder, and here's the edge of the rotator cuff tendon. It should be coming over and attaching over here. This is the muscle here. This is the tendon of the rotator cuff, ball and socket below, and this edge of the rotator cuff we see this white gap where the tendon really should come all the way over here. So that's a really good detailed description of a rotator cuff tear that we can see very clearly on MRI. So now we have to put it all together. We've done the history, we've done the exam, and we've got our diagnostic imaging, and now we have to make a diagnosis. The most common diagnoses that I make are on this screen, so especially in people that don't have trauma. In younger patients, we'll see labrum tears, often the result of a shoulder dislocation or of some other instability type event. A slap lesion is a labrum tear that happens at the very top of the labrum. It stands for superior labrum anterior to posterior tear. We might see anterior labrum tears if somebody's dislocated at the front. We might see posterior labral tears if somebody's dislocated at the back. Rotator cuff injuries, very common. We'll see them again in middle-aged and older patients. It can be something as simple as impingement or bursitis or tendonitis. These are words we relatively use interchangeably, which is really what we call stage 1 rotator cuff problem, which means that we don't have a tear yet, but we have somebody that's progressing along that pathway. Impingement is when the rotator cuff impinges against the undersurface of the shoulder blade. That happens primarily from rotator cuff dysfunction and wear and tear of the rotator cuff. That can precipitate bursitis and tendonitis. So all those words basically mean the same process going on. That process can go on so long that sometimes people will have partial thickness rotator cuff tears. We call that stage 2 rotator cuff problems. You can have a low-grade partial thickness rotator cuff tear. You can have an intermediate grade or a high grade. And that just means how much of the thickness of the rotator cuff is torn. Low grade, maybe 30%, intermediate grade around 50%, and high grade close to 90% or more. And that can progress on to a full thickness rotator cuff, like we showed on that MRI previously. That's where the rotator cuff has completely detached from bone. And that can be a small rotator cuff tear involving one of the tendons of the rotator cuff, a medium involving two, a large involving two or more, and then a massive, meaning almost all the tendons are torn, or one or two tendons are torn, but they're retracted very far away. A lot of times in older patients, we'll see arthritis, and when they have it with a rotator cuff tear, we'll call that rotator cuff tear arthropathy. Arthritis can be the great mimicker. It can seem like a rotator cuff tear. It can seem like a frozen shoulder. It can seem like a lot of other things that can happen at the shoulder. And then obviously we want to always rule out fractures, shoulder separations, or even this other diagnosis called frozen shoulder, where somebody can present with inflammation in the joint that causes an extreme stiffness. And there's specialized treatments for that as well. I have a couple of case examples that we can go through to kind of delineate that kind of age-based approach to how we treat patients with the shoulder. So in the first case, we have a 17-year-old high school football linebacker who presents with sudden pain in his right shoulder after trying to make a block on an offensive lineman. So he's pushing the lineman. The pain is deep in the shoulder. It's worse with activity, not that bad at rest. It's sore when he tries to throw or use his arms strenuously. His exam shows full range of motion. He has pain when we load test his shoulder. When we put it to an extreme and try to dislocate it, he feels discomfort. And he has clicking in his shoulder. His x-rays are normal, but his MRI arthrogram that we ordered shows this. This is the ball, this is the socket, and in the back of the shoulder, we see this labrum with fluid behind it. So this is an example of a posterior labral tear. And in this young athlete who wants to participate at a very high level, oftentimes the best treatment in those patients is going to be a labral repair. And this is an example of what we see arthroscopically when we treat patients. That's the labrum in the back of the shoulder completely torn off the back. This is the labrum in the front. And what we do is we go and we basically elevate that labrum and try to clean it up and separate it from the socket. And once we do that, now we want to reattach it. We clean up the bone in order to allow some healing of the bone. And we want the labrum to be able to reattach. So we want to create a healing environment by removing any scar tissue that might be there. And then once we do that, we place these anchors that have stitches. We pass these stitches through the labrum, and we basically secure the labrum back to the socket, trying to seal that labrum back to the socket from where it tore. And we sequentially place these stitches up the back, and you can see that labrum firmly secured back to the socket. And then when we're done, we'll even close that little poke hole that we made so that it's like we were never there. So that's an arthroscopic technique of somebody who has a labral tear, and that's how we go about fixing it. In my second example, we're moving up the chain here in terms of somebody more middle-aged. This is a 56-year-old painter who fell off a ladder while trying to paint a ceiling, injuring his right shoulder. He has pain in the policeman's patch in the upper arm, the deltoid area. The pain is worse overhead. He has difficulty lifting his arm, and that just sounds like a rotator cuff problem. His exam shows that he has full passive motion, which means I can move his arm, but he's not able to do it. That's diminished active motion. He has weakness lifting overhead. His x-rays once more were normal, and we ordered an MRI. And the MRI shows that he does, in fact, have this defect in his rotator cuff. This white area is a gap where he tore his rotator cuff. And how we repair rotator cuffs is not that dissimilar than labrum. We want to create a healing environment. We put anchors into the bone that have stitches, and you can see this hole here where the rotator cuff hole is here. And we're going to pass these stitches through this rotator cuff tendon in order to repair it. And that's the passing technique. We basically pass the stitches that we placed into the bone through the rotator cuff. We retrieve them outside the shoulder, and then we tie them. And we tie the rotator cuff back down to the bone. And you can see us passing the stitches. And then here we are tying the rotator cuff back down to the bone. So we kind of take that area where there was a tear and now bring that tendon back down to bone so we can get it to heal for the patient. We have to let it heal. And then once it heals, we can start range of motion. We can start strengthening. We can gradually get that patient back to activity. And not everybody needs rotator cuff surgery, but active people who can't lift their arm, they're likely better off having it done. And this is kind of what it looks like when we're done. We repair the rotator cuff back to the bone through the suture construct. My last example that I have is a 72-year-old female who reports increasing pain of several years and gradual weakness of her arm. Her history of pain is both in the front and the outside of the shoulder. She has significant difficulty lifting the arm, and she has pain at rest and even pain at night. Her exam shows a drop arm. She can't even hold her arm up. It falls right back to her side. She has atrophy, which means that the muscles are wasting around her shoulder because they haven't been used in years. We get an x-ray, and this x-ray is a very classic example of somebody who has rotator cuff arthropathy. They have arthritis at the joint, and you'll notice that the ball is sitting underneath the shoulder blade. It's no longer even in the socket anymore. The rotator cuff is torn, so the ball doesn't stay centered in the socket, and the ball has risen and worn away. And so this is a person with severe arthritis of their shoulder and the diagnosis of rotator cuff arthropathy. After they've had extensive treatment that's non-surgical, that's not successful, then they're a candidate for this type of replacement. This is called a reverse shoulder replacement. It's where we take the ball and put it where the socket used to be, take the socket where the ball used to be, and reverse the architecture of the shoulder. And by doing that, now the replacement stays together. It doesn't need a rotator cuff to hold it together. And now the deltoid muscle is what's going to be able to lift the arm up. So this patient not only gets restoration of function, but they also get their arthritis treated in the same setting. So what options do we have for patients? I showed you some 3 examples of people who needed surgery in order to get better, but not everybody needs surgery. In fact, most of the patients that we see in the office with these diagnoses can be successfully treated with rest, anti-inflammatories, and physical therapy. On occasion, we'll do injections to help with pain. That might be a steroid injection. Investigational injections such as platelet-rich plasma and stem cells can selectively be used, but the data on them is less convincing. So we're still waiting for better data and long-term studies on whether or not this is going to have a more important treatment option for patients. When patients do come to surgery, we have a couple techniques. We can do open repair techniques. We can sometimes do arthroscopic techniques depending upon the diagnosis. For arthritis, we can do shoulder replacements, which work extremely well in the right patient. So shoulder replacements are on par with hip replacements in terms of restoring function and restoring pain. And in instances where fractures are really displaced or if they're not fixed, could really compromise function, then we can do open fracture repair as well. So there's a lot of options for patients, and that's why it's best to kind of always have this individualized approach to patient. I always say surgery is not always the answer. Most patients do well with physical therapy or medical management for certain conditions. And we always base our treatment on patients, what their demands are, what they want out of their shoulder, how bad the pain is. And these are, we call that the shared decision-making process. It's us and the patient deciding what's in their best interest. And ultimately, the patient decides. So we consider all factors in a holistic manner to patient's care. We want to know their age, their activity, how long the problem's been going on, what treatments they've had and how successful they've been. If they're an athlete, what position they play, how important athletics is in their lives. Do they have night pain? and the likelihood of success of any treatment. Sometimes patients will want certain treatments, but it's maybe not the right thing for them. So we want to make sure that if they choose a treatment option, that it's going to be the right thing for them to do. So that's all I have. I want to thank everyone for their attention tonight. It's been a privilege to talk to everyone. And certainly, if anybody has any questions, please don't hesitate to ask tonight.
Great. Thank you so much. That was really informative. I learned a lot about the shoulder. I never knew. So if you have a question, if you can put it in the Q&A box and we will go through and read them and Dr. TJ will answer them. We do ask that we keep the questions to a more general audience, not anything specific to your care. But yeah, so we'll just wait a minute and see if anything pops up in the Q&A. Thank you.
Everybody's good, it sounds like, huh?
You must have been very clear. We'll give it another. Oh, wait. Oh, here we go. Um, oh, okay. Can you see them? Do you want me to read them to you, or do you want to just
I
go
do.
through?
I see
Okay.
them. One says, how do you prevent chronic rotator cuff pain? So that's a great question. I think one of the things is that certain things that you do in your life may predispose you to having rotator cuff issues. A lot of overhead things, a lot of things that are repetitive may predispose you to having rotator cuff issues. So strengthening your rotator cuff, like a baseline rotator cuff strengthening program, can go a long way towards helping to prevent injury. By having a strong rotator cuff and a strong shoulder, you can sort of help to eliminate some of those mild discomforts that you may have when you're working overhead. Sometimes it's just inevitable. Some people have genetic predisposition to rotator cuff disease. Some people have occupations that require them to lift overhead. So there's a lot of ways that you can come to a rotator cuff problem. But I do think sort of incorporating a good rotator cuff strengthening program into a regular exercise regimen can be very helpful in preventing that. So, so the next question says, can a shoulder orthopedic surgeon tell on an X-ray if the person needs a reverse total shoulder replacement or a regular one? Is an MRI required? So that's a great question. So it really depends. Like when I had a patient in this example where you can clearly see on the X-ray that the ball is no longer contained in the socket, an MRI is not going to add that much more information. If I have a patient though that's in their 70s and they're going on for shoulder replacement, we do like oftentimes to know whether or not the rotator cuff is affected, and we will want to get an MRI because we don't want to do a regular replacement and then have it not work as well because the rotator cuff is a problem. So it's a great question, and I think it's really patient specific, but in some instances, the X-ray is plenty. As far as the recovery for shoulder replacement, so shoulder replacement, think of it kind of in various stages. The first stage, we immobilize you a little bit. So you'll be in a sling for about 4 or 6 weeks. During that time, you're coming out of the sling for some light therapy, but nothing real strenuous. You're using your wrist, your hand, and your elbow. The second 6 weeks, now you're coming out of the sling. You're working more to get more achieve a normal range of motion, but not doing a whole lot of strengthening yet. And then around 3 months, we'll start to do a lot more strengthening of the shoulder. And most patients will recover a period of 3 months to 6 months. I consider full recovery at 6 months with partial recovery at about 3.5 to 4 months. One patient says there's pain in the morning, but it goes away a few hours later, no weakness, and able to play golf. So it depends. I mean, normal aches and pains can be arthritis. It can be just normal wear and tear of the joint. I think if the pain really persists, or there's certain things that you can't do, or you're getting this characteristic pain down the side of your arm, that could indicate some rotator cuff issues. If you're able to manage it with light exercise and it's not that impairing to your activity, then I think you're probably fine to just kind of continue as you are unless the pain worsens. Somebody says, is there much I can do to relieve pain and avoid surgery? I play tennis and golf and I'm concerned about recovery. I'm 67. So the first thing that's important is to know, like, if this is a rotator cuff tear, well, what are your goals? What's the rotator cuff tear look like? Is it a small tear? Is it a big tear? Different size tears, different chronicity of tears will have different response to treatment. Many patients can do well with physical therapy and avoid surgery. A really dedicated physical therapy program that you commit to with a good therapist to show you the exercises can really go a long way to helping to prevent surgery and to control pain. So it's check in with your orthopedic surgeon, your shoulder specialist, evaluate that MRI, and see whether or not that's the best treatment option for you. If a supraspinatus tear in a 69-year-old isn't fixed, will it lead to frozen shoulder later in life? So not necessarily. I mean, frozen shoulder is a condition where there's scar tissue in the shoulder and it limits your motion. Rotator cuff tears can limit motion because you just don't have the strength to lift your arm. So they're kind of two different things. Now, sometimes people can have a rotator cuff tear and it causes them not to want to lift their arm and they can develop scar tissue and a secondary frozen shoulder. But rotator cuff tears don't necessarily lead to frozen shoulder. So all great questions though. So can cortisone injections hinder physical therapy? So, I don't think they hinder therapy. I mean, we're always cautious about how much cortisone we give. We don't want to cause more problems than a patient has. And so we want to make sure that you're not overdoing it on cortisone. We don't want to mask symptoms so much that you're going out and abusing the shoulder. But sometimes cortisone can be very helpful. It's a good pain reliever. It can help people maximize their physical therapy. So in some instances, it's a very helpful, like sort of adjunct to your treatment course. But we certainly don't want to give a lot of them. And long-term use of cortisone can cause some changes to the rotator cuff and soft tissues that we want to avoid.
There's a couple questions that got posted in the chat instead of the Q&A. So can you see the chat or I can read it to you?
I can see the chat too. Yeah, let me see. Let's see. 82-year-old full range of motion, pain below elbow, X-ray ordered, no results, ice recommended. So it's hard to say. It might not be the shoulder at all. It could be a pinched nerve. It could be something at your elbow. So it's important to get a good diagnostic evaluation. How does bicep tendonitis fit into this? How can you tell if a tear is the problem or tendonitis? I understand not all tears cause pain. Some patients have both. I'm trying to figure out which is causing the pain. Doctor wants to do surgery, but I'm a fitness instructor and don't want to be out of work that long, considering the pain is not that bad. So what we will often see is that biceps tendon problems of the shoulder are not typically the main problem. There a lot of times people will develop biceps issues because the rotator cuff is affected. And now your biceps is trying to pick up the slack of the rotator cuff and it gets overworked and inflamed. You can't always tell the difference just from an examination of tendonitis versus a tear. So we look at things like weakness, we look at things like atrophy, but in some instances, when patients don't get better, the next step is to get an MRI so we can get more granular about whether or not it's a tear or just tendonitis. Um, let's see. For Douglas, it's hard to say, Douglas. I mean, if you felt a twinge at the end of the collarbone, it could have been a slight sprain. It could have been a sprain of your rotator cuff. If it went away, just kind of look for any recurring symptoms. What are the more common NSAIDs recommended for slight shoulder pain? Over-the-counter ibuprofen many times. We might use Aleve, which is naproxen, right? Over-the-counter. There's a lot of different ones on the market. Some people do well with Advil, some do well with ibuprofen, which is the same medication, but sometimes that formulation helps patients. Can a shoulder problem be repaired by physical therapy? It may not structurally heal the problem, but you actually may feel significantly better. There have been studies looking at side-by-side comparisons of people who get physical therapy for the rotator cuff tear and get surgery. And there have been good studies that show good results between both and not that much of a difference. So in many patients, physical therapy can do a great job. It doesn't necessarily repair the underlying problem, but from a symptom standpoint and from a function standpoint, people can get back to activity.
Got a couple more in the Q&A here.
Yeah. How might my shoulder pain relate to chronic neck pain? It's really important to have your neck pain evaluated to make sure it's not a pinched nerve that could be referring pain to your shoulder. We might sometimes do diagnostic injections. For instance, give you an injection of lidocaine at the shoulder to numb the shoulder to see if the pain is still there. If it is, it might be coming from your neck. So there's little things we can do to help to differentiate that. What is the risk percent for fracturing the scapula for a woman age 75 with osteopenia? Well, that really probably is going to depend on trauma. Like most people are not going to fracture their scapula unless they fall, have a motor vehicle accident, or some kind of trauma to the shoulder. Certainly with osteopenia, it's higher risk, but it's hard to put an exact percentage on that. So, does difficulty sleeping on one side of the body indicate possible rotator cuff injury? Can you have a rotator cuff injury and still be able to move your hand above your head? Yes, you can have a rotator cuff tear and still lift your hand over your head because there's a lot of overlap in the rotator cuff muscles and how they function. So being able to lift your hand over your head doesn't mean you don't have a rotator cuff tear, but it means you're functioning pretty well with it. Sleeping on one side or the other, sometimes, to be honest with you, some people sleeping on the bad side feels better because they pin it in and it's not moving as much through the night. So sleeping on one side versus the other is not all that informative. So yeah, so I mean, overall, I think that good questions, and that's where this a lot of the questions sort of point to, will therapy work for me? Is this the right treatment for me? And that's why it's really important to have that discussion with your treating physician, so you can ask those questions for your specific tear. One of the nice things about rotator problems or shoulder problems is they've been extensively studied, so we can get very granular with patients about what they can and can't do, and then their prognosis with treatment. So how does osteopenia affect the risk factors of a total shoulder reversal plan? So it's concerning, right? Because, when you have osteopenia, when you have osteoporosis and you get a shoulder replacement, that replacement does pull through the joint a little bit. And patients with osteopenia or osteoporosis are at slightly increased risk of stress fractures. Now, it's not high. It's about 2% or 2.5%, but it can happen. So it's something to certainly be aware of. And there are little strategies you can employ post-operatively to help you to reduce them.
I think we got all of them. Did we do the shoulder pain relating to chronic neck pain?
Yeah, how to
Okay.
differentiate that, maybe a
Sorry, I'm
diagnostic.
reading and answering at the same time, so I might have missed that one. Well, I guess we can end it now. Thank you so much. I have my telephone number and my email in the chat. If anybody has any more questions, you can reach out to me. I can easily get you an appointment with Dr. TJ. Like he said, he sees patients in Egg Harbor Township as well as Manahawkin. So everyone should have my email, my contact information. Happy to help. And thank you so much for taking time out of your evening to spend a little time with us. Thank you, Dr. TJ. Appreciate you.
Thank you, everyone. Good night.
Alrighty. Good night.